Good morning, endocrine learners. Today, we will be reviewing endocrine emergencies. At this point, you should have opened or printed out the log, which will allow you to kind of fill in the disease processes and conditions as we get through them, writing down the signs and symptoms, treatments, and miscellaneous information. It's just a nice way for you to keep things organized as we move forward. You don't have to use it, but I think it would be beneficial. You should have also opened up or printed out the endocrine system handout. Again, this is a document that kind of groups the disorders by the specific glands. So you can always review back to that and see an overview of all the disorders that we're going to be speaking of today. So unfortunately for you guys, what I usually do for this lecture is bring in hummus, carrots, grapes, pretzels, emergency packets, some really good, healthy, sustainable food while we talk about blood glucose levels. So maybe in the absence of that, you guys could make your own hummus, bring your own hummus to the table. So we'll pause this, go ahead and go make your hummus, and we'll see you back in a few minutes. Okay, so if anybody actually made their own hummus, you get an automatic A. Okay, let's move on. So, endocrine day. It's that simple. Look how simple it is. What is it? Essentially the definition, right? Then we're going to talk about what body parts are involved, which is essentially the anatomy. Then we're going to talk about what those body parts do, physiology. And then what kind of emergencies does this body system have for us? The pathophysiology. How do I recognize them? We're going to learn how to recognize them, which is essentially the etiology, right? Recognizing them as an endocrine disorder. And what can I do about them, which is the treatment. Then review, and then go home. But you're already home, so we could just take that one right off the list. You're already home. Also, at this point, you should have already completed the pre-test. I believe you weren't allowed to move forward until you completed that. So at the end of the lecture, we'll kind of review the pre-test and see if you would have chosen any different answers. We're going to kick things off with a video. You can stop the video at about 8:55. It's interesting information, but it's not required for you under your educational standards. So I'll see you on the next slide. Each time you see one of these calming, beautiful nature pictures, in class, we would have gotten up and done a breathing exercise or a stretching exercise. However, we're not going to do this in the asynchronous learning format. So when you see these pictures, you can make your own choice if you'd like to get up and stretch, yawn, or just sit there and drink your coffee and keep going. Here is just a visual diagram of what you just learned in your video. Today, we will primarily be discussing the hypothalamus, the pituitary gland, the thyroid gland, the thymus, the adrenal glands, the parathyroid glands, the pineal gland, the pancreas, and the gonads. Now the real heavy hitters that we're going to delve deeper into that contribute to more endocrine emergencies are the thyroid gland, the adrenal glands, and the pancreas. With all the intricacies of the endocrine system, the bottom line is this. It's simply a network of glands that produce and secrete chemicals called hormones. Right? There's about 50 hormones in the human body. We would need a whole semester to learn about all of the hormones, the chemical makeup, and what they do inside the body. So our goal by the end of today is to have learned the heavy hitter hormones that contribute to endocrine system disorders and or emergencies. You can liken the endocrine system to a subway system, right? Each hub stop is a gland. The train cars would be the blood vessels. The people within the trains would be considered the hormones, just trying to get to their target endpoint. And remember, the main function of the endocrine system in the body is to maintain homeostasis. And we know, of course, that homeostasis is simply just a balance within the body. So I told you in the previous slide that there's about 50 hormones in the body. I know the slide says 30, and different resources will tell you different numbers. That number is not incredibly important. That's just semantics. So hormones, among many other things, help regulate sleep, body temperature, hunger, stress management. Essentially, a hormone is released in one tissue from one gland and transported in the bloodstream, right? It's looking around for its target tissue. It's only going to match up with the receptor sites that it fits with. So picture yourself walking around the 4th floor of the Florestano building and all the doors are locked and you just have one key. You're going to keep meandering around, right? Trying all the different doors. You're going to stay in the hallway until you find the door that your key fits. And that's how hormones work, right? They're trying to find their target tissues that they match with. And sometimes their target tissue is another gland, and the goal is to stimulate that other gland to secrete even more hormones. We'll go a little more in depth in the next slide. Hormones work in different ways. In layman's terms, hormones could go to a receptor site and say, hey, please make me that enzyme that I need. They could head to a receptor site and say, hey, slow down the production of that enzyme or speed up the production of that enzyme. They might also go to a receptor site and essentially turn it on or off, like closing the door or opening the door. You've learned about the nervous system in previous content. Now we're learning about the endocrine system. Let's explore some of their similarities and differences and how they both work in tandem to maintain homeostasis within the body. You'll see on this slide that nervous is bold, right? Nervous versus endocrine system, but this slide is specifically talking about the nervous system. So remember that the cells of the nervous system are called neurons, right? And over on the right here, you'll be reminded, oh yeah, there's the axon, the dendrites, there's the synapse between the neurons, and the messengers of the nervous system are called neurotransmitters, right? You'll see a list of a few neurotransmitters down here, acetylcholine, serotonin, norepi, etc. Can you come up with any other neurotransmitters? The takeaway with the nervous system is that it's a way of communication in the body that can happen really quickly, right? You can get very, very quick messages from one place to the next in the body. So we think about the nervous system as a high-speed cable network, right? We'll compare that in the next slide with the endocrine system that will liken to a 14.4 dial-up modem. Did anybody ever have one of those? Or am I just too old? All right, the takeaway here, the bottom, it says the take home for nervous system is that it's fast, short-lived, and the communication is had by the neurotransmitters. In comparison, we have the endocrine system, and you'll see up top how endocrine is in bold. Now, unlike the nervous system, the endocrine system is a slow-moving process, right? We say it's for long-term processes, like the dial-up modem we spoke of. Right? The endocrine system actually involves every single cell in the body. The nervous system does not have the ability to speak with every cell in the body. And remember, endocrine glands secrete hormones directly into the bloodstream. The gland itself secretes the hormones into the vasculature within the gland, and then the vasculature carries the hormones outside of the gland and into the bloodstream, so it can search around the whole body for its receptor sites. So again, the take home here for the endocrine system, unlike the nervous system, is that it is slow, long-term communication, right, for long-term processes. Let's apply what we've just learned. So I'd like you to read through these two examples and come up with which system is responsible. You are absolutely correct. Number 1 would be the nervous system, and number 2 would be the endocrine system. Let's explore another type of gland called the exocrine gland. So we've already learned that the endocrine gland, remember, meaning inside secretions meaning the endocrine glands secrete hormones directly into the bloodstream from inside the gland itself, right? And those hormones stay within the body. Exocrine glands, on the other hand, excrete chemicals for elimination. Exocrine glands all have ducts. They have a duct system that can move these chemicals either to the outside of the body or into another body cavity. So I have some examples here like sweat glands or salivary glands. So take a second and see if you can come up with a few more exocrine glands. Good. For example, mammary glands, lacrimal glands, sebaceous, and remember the pancreatic duct, right? That is also, the pancreas is an exocrine gland and an endocrine gland. The pancreas secretes its pancreatic enzymes into the small intestines through the pancreatic duct. That is the pancreas's exocrine function. Let's take a look at how cells communicate. So we have a gland that's going to secrete a hormone, right, into the bloodstream. And that hormone is considered the messenger. It's going to float around until it finds its receptor site. Once it finds its receptor site, it's going to bind and tell that receptor to decode the message that it has. We can correlate this with a conversation between people, right? You have a speaker. That's me. I'm the gland right now. Or, in my example here, it's grandma. And you have a message that I'm giving you. That's the hormone in the bloodstream. That's the message looking around. Or in my example here, it's grandma talking about the weather, right? Then we have to have somebody that's listening on the other end, right? That's the receptor cell, just waiting to receive that message, right? So it's you guys either listening to me or just scrolling through the PowerPoint, or it's grandma's message about the weather, which you're receiving or spacing out. We mentioned earlier the words chemical structure of hormones. I don't want you guys to necessarily memorize all of these, but I do want you to understand that some hormones are able to penetrate through the cell membrane and talk to the nucleus, and some are not, and they simply bind to the membrane to send their message. Woo-wee! I was going to tell you guys a joke about amnesia, but I forgot it. So we learned earlier that the goal of the endocrine system is to help maintain homeostatic balance within the body. Well, it can't just do that out of thin air. It actually has to do that via feedback mechanisms. And we have two primary feedback mechanisms that the body uses: positive feedback and negative feedback. Negative feedback is by far the most common feedback system in the body. With negative feedback, when something happens, the feedback message is to make it stop happening. And with positive feedback, when something happens, the feedback message is to make it keep happening. So we'll explore some of those in the next slides. A simple example of a negative feedback mechanism is your toilet. The float valve will realize that the water is too low and sends a message to get more water. Water begins to fill the tank. And then the float valve realizes that the water is normal and simply stops sending a message to fill. We are now back to homeostatic balance. Another example of negative feedback: heating and cooling systems. So if your thermostat is set to 72 degrees, and if it stays at 72 degrees in your house, then you're essentially at homeostatic balance. Now, outside, the sun's come up and the temperature inside the house starts to rise a little as well. Now the thermostat says, hey, we're now above 72 and our homeostatic balance is at 72. So the message it relays to to the air conditioning unit is that we need to cool. So the air conditioning unit sends cold air and the thermostat keeps reading the temperature. And once the thermostat now reads the temperature of 72, it simply stops sending a message that there's something wrong and we're back to homeostasis. Just like the home thermostat example, our body has its own thermostat, right, to maintain our normal temperature. You'll see in this feedback loop, it starts with number 1, where the body temperature decreases. Let's say this patient is becoming hypothermic. They're outside and they're unconscious and their body is becoming colder. So the body recognizes that we're below our homeostatic balance of 98.6 and tells the body to take actions to increase the temperature. One of those ways would be by shivering until the body temperature reaches 98.6 again, and then we stop sending the error message. Now let's explore some positive feedback mechanisms. Again, remember negative feedback is by far the most common, but there are a few positive feedback mechanisms within the body. With positive feedback, remember there's a deviation and the body says keep going. This is a good thing. Make it keep happening. Versus negative feedback where when there's a deviation, the body says let's get back to normal. Stop this from happening. If the thermostat example was a positive feedback loop, then once the heater kicked on, it would just continue. The thermostat would say, hey, this is great, good feedback. I like this too, let's keep going, right? And then we would fry our heater. Blood clotting and childbirth are 2 examples of positive feedback loops within the body. Take a second and see if you can understand why these are positive feedback loops. So when we're bleeding, platelets immediately aggregate, which then precipitates the entire clotting cascade. And the body will continue this cascade until the bleeding stops. So let's imagine we're in lab and you're performing and I'm giving you feedback. I'm giving you positive feedback and say, hey, you're heading in the right direction. That's looking really good. You're likely to keep doing it, right? You're going to keep doing that behavior. If I give you negative feedback and say, you don't have it. You need to get yourself back together. That would be negative. So if we were in class, we would gather into small groups and come up with some different positive and negative feedback mechanisms and get creative with it. We don't have the ability to do that now. So on your own, if you'd like to come up with a couple of different positive and negative feedback loops, whether that be within the body or not, then please drop them in the discussion board for me. All right, guys, great job so far. I actually don't know if you're doing a great job because I cannot see you, but let's assume you're doing a great job so far. Great job. All right, and we're going to move on together. So next, we're going to review the actual hormones and glands. And here I've created a list for you of the possible things that could go wrong with hormones to create these endocrine disorders and emergencies. Let's remember the video from earlier and review some of the endocrine organs and glands. We'll review each one of these individually in the coming slides. This is simply a chart of the glands, the hormones they create and or secrete, and the actions of those hormones. So don't be concerned as much of the type, that third column there, type. You don't have to commit those to memory. Let's start from the top and talk about the hypothalamus. The hypothalamus is a major player in the endocrine system. The hypothalamus is not considered an actual endocrine gland, right? It's just a small portion of the brain. And it is a nice link between the endocrine and nervous systems, so the endocrine and nervous systems can talk to each other. Now, the hypothalamus secretes several hormones, and luckily you don't have to memorize those. Most of the hormones that the hypothalamus secretes are called releasing hormones, meaning those hormones go to other glands and tell those glands to create and secrete their own hormones. So we do not have to memorize the hormones that are created and secreted by the hypothalamus, with the exception of 2 because they're stored in the pituitary gland, and we're going to review that in a second. The pituitary gland. We call the pituitary gland the master gland. It has major control over the secretions of the other endocrine glands. It sits just below the hypothalamus and is actually connected to the hypothalamus by a bit of tissue. And remember in the last slide we talked about the hypothalamus creating two hormones that are stored in the pituitary gland. And we'll explore those in the next slide. Remember, the pituitary gland has an anterior portion and a posterior portion. So we have the anterior pituitary and the posterior pituitary. Now the anterior pituitary produces and releases 6 major hormones: growth hormone, thyroid stimulating hormone, adrenocorticotropic hormone, melanocyte stimulating hormone, and your 3 gonad hormones, which are follicle stimulating hormone, luteinizing hormone, and prolactin. That might seem like a whole lot to remember, and it is. But as we speak about each gland, it'll be easier to correlate these hormones with the glands. The 2 hormones created by the hypothalamus but stored in the posterior pituitary are antidiuretic hormone and oxytocin. Let's talk about antidiuretic hormone first, or ADH. Think about that for a second. Antidiuretic. We know that a diuretic means what? It eliminates fluid from our body. So antidiuretic hormone helps us retain fluid in the body. This is secreted when the receptors in the body sense that the plasma is either too concentrated or sense when the blood pressure falls. So the posterior pituitary then secretes antidiuretic hormone and encourages the kidneys to reabsorb water into the collecting ducts so that we increase our overall fluid volume. Next, we'll speak about the thyroid gland. You'll see we're just moving in a systematic order from the top to the bottom of the body. And the next gland we fall to is the thyroid gland. The thyroid gland is located in the neck, just below the thyroid cartilage, or the Adam's apple. The primary purpose of the thyroid gland is to regulate metabolism throughout the whole body. Every single cell in the body relies on the thyroid hormones to regulate metabolism. You'll see here that it says that the thyroid gland is stimulated by TSH. Does anybody remember where we just saw TSH? That's right, from the anterior pituitary. TSH is thyroid stimulating hormone. Remember, the anterior pituitary creates and secretes multiple other hormones that go speak to other glands. So in this case, the anterior pituitary creates and secretes thyroid stimulating hormone, which courses through the blood to the thyroid gland and then stimulates the thyroid gland to produce its own hormones. The 2 hormones that the thyroid gland is responsible for are thyroxine and calcitonin. We'll speak about them a little further in the next slides. The thyroid gland is the only tissue in the body that can absorb iodine, and it requires iodine to create the thyroid hormones. We see here that it says T4 and T3. T4 is actually considered the free thyroid hormone. T4 is actually converted into T3 in the tissues. So for our purposes, we're going to consider T4 and T3 thyroxine. Remember we said before that every cell in the body relies on the thyroid hormone to regulate its metabolism. So when we have too much or too little, it can literally wreak havoc on every body system that we have. Calcitonin is the second hormone that the thyroid creates and secretes. The goal of calcitonin is to lower the amount of calcium in the blood. When the amount of calcium in the blood becomes too high, it triggers the thyroid to release calcitonin. A way to maybe correlate that is to think of calcitonin. Calcitonin lowers the calcium levels in the blood. And it does that by stimulating the bones to resorb calcium and stimulating the kidneys to excrete extra calcium. You'll see in a moment how calcitonin works in conjunction with the parathyroid hormone to regulate concentrations of calcium. The parathyroid hormone actually does the exact opposite of calcitonin. Now's a good time to jump back and see how feedback control correlates with what we just learned about the thyroid gland. Parathyroid. The parathyroid glands live on the thyroid gland. Like I said in the previous slide, parathyroid acts the opposite way that calcitonin does. Its goal is to increase the levels of calcium in the blood when they are too low. This is done in the opposite fashion of calcitonin. It actually stimulates the breakdown of calcium that's stored in the bone to release it into the blood. It also tells the kidneys, hey, please stop excreting all that calcium. We actually need to keep it in the body. Which type of feedback mechanism is this? You'll begin at homeostasis disturbed. If you came up with negative feedback mechanism, you'd be correct. Moving down the body to the thymus. The thymus is located in the mediastinum, just posterior to the sternum. It produces the hormone thymosin. Thymosin stimulates the production of your T cells. The thymus actually atrophies at about puberty, and by the age of 75-ish, it just becomes kind of a lump of fatty tissue. But luckily, it produced all of the T cells it needed to before puberty. The gonads. They're actually called the gonads. There are sex hormones. For men, it's the testes that produce the androgens. And the most potent androgen is testosterone. For women, we create estrogen and progesterone from the ovaries. The adrenal glands. The adrenal glands sit on top of the kidneys, aka suprarenal. There's two parts to the adrenal gland. There's the middle, and then there's the outside. The middle is called the medulla or the medulla. The outside is called the cortex. And a good way to remember those is cortex sounds like Gore-Tex, like a Gore-Tex jacket. And medulla or medulla looks like the word middle. The adrenal cortex secretes our corticosteroids. The adrenal medulla is what excretes our catecholamines. We'll go into this a little bit further in the next slides. But what's important to note is that the adrenal glands are stimulated by ACTH. Do you remember that from earlier? It stands for adrenocorticotropic hormone, and it is created in that's right, the anterior pituitary. The anterior pituitary creates and secretes ACTH. ACTH heads to the adrenal gland and tells the adrenal gland to secrete its hormones. But this one's kind of easy. Just like thyroid stimulating hormone, the word thyroid is in the name. Here, adrenocorticotropic hormone, right? Adreno for adrenal, corticotropic for corticosteroids. There are two hormones secreted by the adrenal cortex, are two corticosteroids. Cortico, meaning they come from the cortex, steroids, meaning they're steroidal. So the two corticosteroids are cortisol and aldosterone. Broken down further, aldosterone is considered a mineralocorticoid and cortisol is considered a glucocorticoid. However, they are both corticosteroids. We'll just kick back and think about the autonomic nervous system for a second. And remember what happens when the sympathetic nervous system is stimulated. The release of catecholamines. And like we learned a couple slides ago, they originate from the adrenal medulla versus the corticosteroids that come from the adrenal cortex. So during a stress response, catecholamines are released from the adrenal medulla. You guys remember what your catecholamines are? That's right, epinephrine and norepinephrine, aka adrenaline and noradrenaline. And we remember, based on the alpha and beta agonist response, this increases our heart rate, respiratory rate, and blood pressure. All right, let's talk a little further about cortisol. Cortisol is considered the stress hormone. I'm sure you've all heard that before, the stress hormone, cortisol. And remember, cortisol comes from the adrenal cortex in response from adrenocorticotropic hormone that comes from the pituitary. Right? Cortisol heads out to most cells in the body and tells the body to increase some energy production. It stimulates processes to bring extra sugar into the bloodstream so we can use that extra sugar to fight off whatever stressor there is. Cortisol also suppresses the immune system. That's why people on chronic corticosteroids may have immune system suppression. Cortisol also decreases inflammation by decreasing the histamine response. This is why people with chronic inflammation take corticosteroids. Aldosterone. Remember, aldosterone and cortisol are the hormones secreted by the adrenal cortex. Aldosterone is involved in fluid regulation. So it's secreted by the adrenal cortex when our blood pressure is low and we are dehydrated, when we are hyponatremic or hyperkalemic. All right, it talks to the kidneys and says, hey, I need you to reabsorb some of that salt from the urine because remember, water follows salt, therefore increasing our overall volume. This may sound a lot like ADH, like antidiuretic hormone, and you're right, because at the end of the day, both hormones, ADH and aldosterone, will increase our blood volume and blood pressure, short and simple. So don't get into the intricacies of how each one works. I just want you to understand that short and simple. These two hormones, by slightly different mechanisms, will increase blood volume and blood pressure. The pancreas. We have finally gotten to the pancreas. Remember, the pancreas is both an endocrine and an exocrine gland. We talked about its exocrine function a little while ago. Let's focus highly on the endocrine function of the pancreas. The islets of Langerhans. The islets of Langerhans live inside the pancreas, and inside the islets of Langerhans live the cells that release glucagon and insulin. And remember, glucagon and insulin are highly responsible for the maintenance of our blood glucose levels. They work in tandem all day long to regulate our blood sugar. So broken down further, the alpha cells within the islets of Langerhans release glucagon, and the beta cells within the islets of Langerhans release insulin. Maybe a good way to remember that is you have a little beta fish named Insulin. Isn't he cute? Just look at him, that little beta fish named Insulin. And then the alpha cells release glucagon. You have the alpha male named Luke. He sounds like an alpha male, Lucagon. So let's talk about blood glucose levels for a moment. So the normal adult blood glucose level is roughly around 60 to 120. And remember, glucose, right, is the body's fuel. Glucose is simply sugar, right? And sugar is needed to create energy. And remember back in biology, you learned about ATP, adenosine triphosphate, which is energy production. Right? So remember that insulin and glucagon work in tandem to regulate blood glucose levels. Let's talk about some basic definitions. So glucose is one single sugar molecule. All right, and our cells can only uptake one sugar molecule at a time. Now, our body also has the ability to store glucose in the form of glycogen. So when we have extra, our liver and our muscle tissues will store the extra glucose. But it won't do that until it binds them up, right? It's like it shoves a bunch of glucose molecules into a suitcase and zips it all up and then stores it for later use. And when we need it later, when we need sugar later, our body breaks down the glycogen into glucose molecules and sends each individual glucose molecule out into the blood for uptake. All right, so let's talk about glucagon and insulin and how they really work and what their actual roles are. So glucagon's role is to increase blood sugar level, right? By talking to the liver and the muscle tissues and asking it to break down that stored glycogen into single glucose molecules to send out into the blood. And that process is called glycogenolysis. So that's a fancy word, glycogen, right? We've taken the glycogen and broken it down. Remember, lysis means breakdown. So You might recognize the word glucagon from a medication we give. So glucagon lives within our body, but we can also give it from the outside, right? When we give someone a shot of glucagon, glucagon talks to the liver and the muscle tissues and tells it to break down the glycogen into sugar molecules. So we get sugar molecules into the blood, and i.e. into the brain, and help someone wake up. It works much slower than putting actual sugar straight into the vein like we do when we give dextrose, but that's the process of how glucagon works. Insulin, on the other hand, is used to decrease blood glucose levels. Okay? It kind of has two jobs. So insulin allows our cells to uptake the sugar. We think of insulin as the key to each cell. The insulin must come and unlock each cell door for the sugar molecules to go inside and work. And remember, every cell in our body needs sugar to metabolize for energy. The other goal of insulin is once the blood sugar level is at a normal range and all our cells have all the sugar they need for the moment, it tells the liver to store the glycogen, right? It tells the liver to store the extra. Now this is a term called glycogenesis. So glyco meaning sugar, genesis meaning create new sugar. So that's the fancy word for taking the extra sugar molecules, putting them in the suitcase, and storing them in the liver and the muscle cells. Glycogenesis. All right, so critical thinking moment. Without insulin, we know that the cells cannot take in glucose. That means the cells, every cell in the body, including the brain. What happens? That's right. The amount of sugar in the blood will skyrocket. And that puts us into what condition? If you answered DKA, you'd be correct. Okay, let's learn one more term. Gluconeogenesis. Remember a moment ago we talked about if we don't have enough insulin, then the glucose molecules can't get into the cells, right? And then the level of sugar in the blood rises, right? So our blood glucose level goes way too high. Now, our body has a way to combat that, and that's what brings us to the term gluconeogenesis. So with gluconeogenesis, if we break down the word, gluco meaning glucose, neo meaning new, and genesis, like we said, means creation of. So we create new glucose from non-sugar, non-carbohydrate sources. Remember, sugar is considered a simple carbohydrate. We have simple and complex carbohydrates. Sugars are just simple carbohydrates. So our body thinks we don't have any, right? Because it can't get into the cells. So our body says, it's okay, I have a way to turn fats and proteins into sugar so that we can use them. And that process is called gluconeogenesis. And again, when we start talking about DKA later, you understand what happens when gluconeogenesis happens and why we create waste products and end up in a ketoacidotic state. All right, guys, welcome to Medical Emergencies Endocrine Style. So what you find here is that there's a lot of non-specific symptoms, a lot of symptoms that are similar between conditions, but what we're going to do is pick up on the keywords or the standout symptoms for each condition to try to help us correlate it. Another thing is that, unfortunately, there's not a whole lot that we can do in many of these endocrine conditions or emergent situations. Obviously, as we run through them, we'll find out the ones where we can intervene, but we will also learn about definitive care for each condition. This would be a great time to grab your empty endocrine conditions chart and start filling it out. You also might think, oh my gosh, we have a lot of slides left, and we kind of do, but we're going to move through some of those slides rather quickly. And there's some redundancy within the slides because I like to give you guys multiple ways to kind of visualize these conditions. So there might be 5 slides of just pictures of a specific condition and the signs or symptoms. So we won't be here forever. Something that's important to note is that individuals having endocrine emergencies most likely often suffer from an endocrine condition, and they're simply having an exacerbation of their condition. So a lot of people have endocrine disorders. That doesn't mean that they're having an endocrine emergency. So in this list here, I'm giving you some things to look for to maybe key you in that a person might have an endocrine disorder. All right, looking over at body alterations, I think we all know what gigantism is and dwarfism. What is acromegaly? You guys remember acrocyanosis? So acromegaly, good, is large peripheries, large hands, large feet, large head. What is tetany? Tetany is essentially muscle spasms. And remember, we primarily need calcium in order to have smooth muscle contraction. So if we have a problem with low calcium, we can end up having tetany. Exophthalmos. It's a word that you're going to hear a lot of. We're going to look at some pictures coming up here soon, but exophthalmos, if you think of what X means, and then opthal means, put those two together. What do you think? All right, we'll look at a picture on the next page. Hirsutism. Anybody know what hirsutism is? Again, we'll look at a picture on the next page. That's abnormal hair growth. So here we have dwarfism, gigantism, hirsutism, and exophthalmos. Exophthalmos. And the eyes look like they're exiting their orbits. And it simply has to do with the connective tissue that is actually in the eyelid that retracts and makes it appear like the eye is bulging out. What we'll find here in a little bit is it's very common in patients with hyperthyroid disorders. So, gigantism and dwarfism are associated with a growth hormone, either too much growth hormone or not enough growth hormone over time. Remember we talked about antidiuretic hormone earlier. We talked about how it's created in the hypothalamus and stored in the posterior pituitary. Two conditions that arise when we either have too much antidiuretic hormone or too little antidiuretic hormone are diabetes insipidus and the syndrome of inappropriate ADH. Diabetes insipidus, though not the same as diabetes mellitus, we have to make that differentiation. Diabetes, the word by itself, just means the excretion of large amounts of urine. The word insipidus means the passing of water. So diabetes insipidus is completely different than diabetes mellitus. Okay, diabetes insipidus happens when there's not enough antidiuretic hormone, not enough hormone that helps us retain fluid. So we end up releasing and excreting large volumes of fluid, and people can become severely dehydrated. The opposite of that is called the syndrome of inappropriate ADH. It's just the opposite of diabetes insipidus. It's where we have too much antidiuretic hormone and we actually retain way too many fluids. So let me throw a scenario out there. You have a middle-aged patient that suffered a traumatic head injury a week prior. Now, this week, he says he just can't stop peeing. He's just going to the bathroom nonstop and excreting large amounts of urine. What do you think's happened here? So let's consider where ADH is made. It's made in the hypothalamus, right? And it's stored in the posterior pituitary. Both of those guys live in the brain. So any trauma to the head can disrupt the normal production and excretion of the hormone ADH. Head trauma can also disrupt the normal outflow and production of all of the hormones or any of the hormones that are made in the hypothalamus or made in the anterior pituitary. So remember that the adrenal cortex creates cortisol and aldosterone. It does this in a response from ACTH, or adrenocorticotropic hormone, that comes from the anterior pituitary gland. Now we're going to talk about two major disorders of the adrenal glands. We have primary and secondary adrenal insufficiency. Primary simply means that the problem is with the adrenal gland itself, right? And secondary, just meaning the problem comes before the adrenal gland itself, meaning secondary is there is not enough hormone coming from the pituitary to encourage the adrenal glands to create their hormones. So although we call them primary and secondary, what I want you guys to take home with you is that not enough cortisol and aldosterone is called Addison's disease. Okay, it's a type of hypoadrenalism, right? Not enough adrenaline. Okay, so whether it be primary or secondary, I want you to correlate not enough cortisol and aldosterone is Addison's disease. The opposite of that is Cushing's syndrome. It's a type of hyperadrenalism, or too much adrenaline. Okay, that's called Cushing's syndrome. High levels of cortisol and aldosterone. Again, there can be a couple different reasons for this, but the takeaway is too much of the adrenal cortex hormones, Cushing's syndrome; too little of the adrenal cortex hormones, Addison's. A couple other adrenal disorders that we'll glance at are pheochromocytoma and congenital adrenal hyperplasia. We'll investigate all of these further in the next slides. It's just a textbook presentation of a patient presenting with Cushing's syndrome. The next few slides will just give you some variations. Moving on to thyroid disorders. Like adrenal cortex disorders, thyroid disorders occur when there's too much thyroid hormones or not enough of the thyroid hormones. On this slide, I've summarized the conditions that we're going to talk about. Remember, the thyroid hormones are responsible for cellular metabolism in pretty much every cell of the body. So let's correlate a low level of thyroid hormone with depressed or low metabolism. We're going to call that hypothyroidism. And then when we have too much of the thyroid hormones, we're going to correlate that with increased metabolism. And we're going to consider that hyperthyroidism. So there's two hypothyroid conditions we're going to speak of. One is called myxedema coma, and the other is called Hashimoto's thyroiditis. Then there's two hyperthyroid conditions we're going to talk about. One is Graves' disease, and one is the thyroid storm. Hypothyroidism. Individuals with hypothyroidism have much lower metabolic activity in every body system. So when we think of hypothyroidism, we think of kind of low and slow and cold. When people are diagnosed with a hypothyroid disorder, they're often put on thyroid replacement therapy. Levothyroxine is the most common thyroid hormone replacement medication. You'll see that listed here below. Two brand names of levothyroxine that you'll come across are Synthroid and Levoxyl. So Synthroid and Levoxyl are two brand names of levothyroxine. So we just talked about hypothyroidism in general, and now we're just going to talk about two hypothyroid conditions. Hashimoto's thyroiditis is a hypothyroid condition. It's actually an autoimmune disorder. The autoantibodies actually attack the thyroid cells. So as these cells die off, the patients may experience a transient episode of hyperthyroidism, transient meaning it comes and it goes, but ultimately these people will end up with a hypothyroid condition. Myxedema coma. As the name suggests, this is pretty serious. It's an extreme manifestation of hypothyroidism, and oftentimes these folks already suffer from hypothyroidism, but like I said in the previous slide, oftentimes these people's underlying conditions are just exacerbated by something. And more often than not, these exacerbations are some kind of traumatic incident to the body, some type of infection, or the ingestion of certain medications. So kind of how we talk about shock, where we have compensated, uncompensated, and irreversible shock, myxedema coma is heading down the irreversible shock route. Right? If you look at the signs and symptoms here, myxedema coma has a pretty high mortality rate if not treated quickly. Hyperthyroidism. So we're going to just speak about hyperthyroidism in general, and then we're going to move on to talk about a couple of the hyperthyroid conditions. So the opposite of hypothyroidism is caused by too much of the thyroid hormone circulating through the body. Too much metabolism, too much heat production, too much activity of pretty much every body system. Graves' disease. Graves' disease is a type of hyperthyroid disorder. It is actually an autoimmune disease causing way too much thyroid hormone to be coursing through the body. Does anyone recognize the person in the picture here to the right? This is Wendy Williams. She's a talk show host. I personally can't stand her, but I thought this was a good representation because she does suffer from Graves' disease, and you can see her exophthalmos. Remember how we said that the thyroid was the only tissue in the body that could absorb iodine? Well, one of the ways to kind of treat this condition is to inject radioactive iodine into the thyroid. So it will absorb the iodine, but the iodine happens to be radioactive, so it will kill and shrink the bad tissue. Another option is the surgical removal of the thyroid. Something to note, however, is that right after a thyroidectomy, patients can experience a thyroid storm where it releases a whole lot more of the thyroid hormone until it's completely gone. Thyrotoxicosis, as the name suggests, is a severe level of hyperthyroidism. It results in toxic levels of thyroid hormones circulating. There can be many causes of this. Now, this is kind of a stepwise progression, because next we're going to talk about a thyroid storm, which is actually a life-threatening condition. Thyroid storm. This is the most extreme manifestation of hyperthyroidism. Often happens in people with hyperthyroid disorders, but remember, like we talked about, people with underlying conditions that undergo some type of stressor, whether that be an infection, a surgery, some traumatic incident, can exacerbate and go into a extreme manifestation of their current condition. Remember how we talked about thyroid hormone talking to every cell in the body and every body system. And remember, if we have an extreme amount of this coursing through the body, think about all the manifestations that can have on the body systems. We have to be really careful because the heart is very responsive to thyroid hormone. The brain is very responsive to thyroid hormone. So thyroid storm can extremely affect multiple body systems. What can we do for these patients? Patients in a life-threatening situation. So the interventions that can be done in the pre-hospital care environment are as follows. So we can attempt to cool the patient because their body temperature should be rather high. We can also administer an antipyretic to help bring down their core body temperature. We can initiate fluid resuscitation. Remember we talked about the effects that the thyroid hormone can have on the heart, as it may put people into tachydysrhythmias. So in regards to the tachydysrhythmias, we must follow our tachydysrhythmias algorithms. But remember, their tachydysrhythmia will likely be refractory to whatever medication or whatever treatment you give them, because the underlying cause is not fixed. Something to note is that thyroid medications are commonly abused as a weight loss drug. They can be very dangerous for pediatric patients to accidentally ingest. Remember, the thyroid talks to the heart as well as everywhere else in the body. So think about the thyroid hormone. If it's excessive, then it's essentially ramping up the metabolism of the heart. So we can see lots of tachydysrhythmias in hyperthyroid states. Now the opposite is true in hypothyroid states. Just thinking about ramping down the metabolism and the activity of the heart, where we would see bradydysrhythmias and slower heart rates. All right, so the big take-home points. When you think hyperthyroidism, think increase in fever, high and hot. When you think hypothyroidism, think decrease in hypothermia, low and slow. Yesterday, I ate a clock. It was very time-consuming, like this lecture, especially when I went back for seconds. We're going to jump into diabetic emergencies, the endocrine emergencies that you'll see the most out in the field. But first, we're just going to do a little review on glucose. I'm going to let you run through the next few slides on your own because it's a review of what we did this morning, or for you this evening, or in the middle of the night, or whenever you're watching this. Quiz question. Is blood glucose level control regulated by negative or positive feedback? If you said negative, that is correct. Look at number 1 here, right? We all just ate a cupcake because we need a little boost. So we ate a cupcake. So the level of sugar in our blood rises a little bit, right? That triggers insulin in the pancreas to release itself so it can go unlock all of the cells so that the sugar can go inside, right? And then if there's any sugar left over, it goes to the liver and it says, hey, I need you to store this for later in the form of glycogen. Remember, I need you to put all these extra sugar molecules from a cupcake in a suitcase and put it in the liver for me for later. And then our blood sugar level decreases back to the normal range. All right, so who knows what NIDDM and IDDM stands for? What are these abbreviations? You're trying to come up with it now. Your words are getting a little jumbled, but you know you have it. You know it's back there somewhere. And you got it. All right. Non-insulin dependent diabetes mellitus or mellitus and insulin dependent diabetes mellitus. So we are going to discuss type 1 diabetes, type 2 diabetes. We'll discuss prediabetes just a little bit. And then you should already know about gestational diabetes from your obstetrics lecture. Mellitus just means sweet. That's where that word comes from. Sweet because glucose is sweet. When we have excess glucose, which we do in diabetic patients because they're unable to facilitate glucose properly, the urine becomes very sweet with excess sugar in it. This may be a little confusing, but remember, the symptoms of diabetes are because of high blood sugar, high blood glucose levels. I know you're thinking, but we run so many hypoglycemic patients. We do, and oftentimes the hypoglycemic patients you run are diabetic patients. However, it's not a symptom. It's just likely due to mismanagement. So remember that glucose is the main fuel for the body. In diabetic patients, they have the glucose. However, they don't create insulin, or they don't create enough insulin, or the cells in their bodies become resistant to insulin, and the body is unable to uptake the sugar into the cells to utilize it. Now that we have the general overview of diabetes mellitus, we're going to break down the types. So diabetes mellitus type 1. So type 1 diabetics. Type 1 diabetes is an autoimmune disease. Okay? In this case, the autoantibodies attack the islets of Langerhans, specifically the beta cells in the islets of Langerhans that produce insulin. So type 1 diabetics cannot produce their own insulin. And since they cannot produce their own insulin, they cannot get any sugar into their cells. This used to be called juvenile diabetes, and you may still hear it referred to as juvenile diabetes sometimes. However, since adults are also diagnosed as type 1 diabetics, we now just use the term type 1 diabetes. As a pre-hospital care provider, you may transport pediatric patients that are in DKA that have not been diagnosed with diabetes yet. We'll learn about DKA in a later slide. The 3 P's of diabetes. Some of the first symptoms to present in new onset diabetics are polyuria, polydipsia, and polyphagia. The 3 P's. So polyuria. What is polyuria? Good. Excessive urination, right? Excessive urination because these folks are creating they have so much glucose in the blood, but cannot get it into their cells, so their kidneys are just trying to get rid of excess glucose, and of course that has to come out with liquid. So that increases diuresis, or eliminating body fluids. Then we have polydipsia. Polydipsia is what? Yeah, excessive thirst. These people are thirsty because they're so dehydrated from peeing out all of their sugar. And then polyphagia. What is polyphagia? Yes, increased hunger, increased appetite. They're hungry because the sugar that's in their body can't get into the cells, and the cells think that they're just starving and they need to eat more food. In the case of the new onset type 1 diabetic pediatric patient, the parents' complaints are usually, hey, my kid just can't get enough water. I feel like they're thirsty all the time. They're always going to the bathroom, or my child that's in diapers, I'm just changing multiple diapers. These are key findings, and you should assess this patient's blood sugar. All type 1 diabetics must take daily insulin. Some wear pumps, some just give themselves daily injections multiple times. So there's multiple different types of pumps too. It can get kind of confusing. The one in the picture here has the pump, has the insulin in the canister here, the infusion set. Right? There's actually a needle under here that goes into the skin subcutaneously. There's also wireless insulin pumps now. Regardless of what type of pump someone might use, the overall goal is to inject a basal amount of insulin usually throughout the day. And then the individuals have the ability to bolus themselves, where they can choose on their pump how much insulin to give themselves based on either what their blood sugar is at the time, and that's called a sliding scale, or they might have a set rate that they're supposed to give themselves after, for example, a high carbohydrate meal. All right, what do you guys think these are? If you guessed insulin injectors and insulin pens, you'd be correct. There's all different types. Where is insulin usually stored? Yes, inside the refrigerator. Please review the following videos. Can you guys come up with the names of some insulins on your own? So here's a list of insulins. Some insulins are short-acting, some insulins are medium-acting, and some are long-acting. I don't necessarily need you to memorize the duration of action, but I would like you to be able to recognize some of these names, like Humalog, Novolog. Those should key you in to this is insulin and this is probably a diabetic patient. Diabetes mellitus, type 2. So type 2 diabetics. This is the most common form of diabetes. Sometimes you'll hear it called adult onset diabetes because it most commonly affects adults. This is the type of diabetes that happens after years and years of likely not the best decisions in treating your own body. So lack of exercise, sedentary lifestyle, poor food choices can affect our cells, right? And they over time, make our cells become resistant to insulin. So usually insulin can come and unlock the door and walk right in. But in this case, our cells are angry and they become resistant to insulin. Like the key's going in and we're shaking the key and we're pushing the door, but we're having a really hard time getting in. The other part that can make someone a type 2 diabetic is simply a decreased insulin production. So the pancreas stops producing as much insulin as it should. And it can also be a combination of these things. So just to recap, type 2 diabetic either doesn't produce enough insulin, has insulin resistance, or a combination of both. So the treatment of type 2 diabetics will really be dependent on those factors. So type 2 diabetics may require insulin, they may not. They may require oral diabetes medications, they may not. And in a lot of cases, if patients are compliant and they have type 2 diabetes or prediabetes, diet and exercise can reverse the condition. Here's a list of oral diabetes medications that type 2 diabetics may be on. There's many different types and they actually have different mechanisms of action. I'm not concerned that you memorize this chart, but again, I'd like you to be able to recognize some of the names of the more common oral diabetes medications, like glucophage, which is metformin. So we use something called the A1C, the hemoglobin A1C. It's a blood test that measures your blood glucose levels over the past 2 to 3 months. And it's what practitioners use to help diagnose prediabetes and diabetes. So here's a recap and a comparison chart of type 1 diabetes, type 2 diabetes, and gestational diabetes. Uncontrolled diabetes can wreak havoc on the body. Remember, non-compliant or poorly controlled diabetics will always have increased blood glucose level, increased blood sugar, and this can affect pretty much every body system. So please review the next few slides and familiarize yourself on the effects of poorly controlled diabetes. So first and foremost, regarding hypoglycemia, I want to make sure we note that hypoglycemia can happen in anyone. Hypoglycemia can happen from not eating enough food, from exercising too much or exercising without eating, taking certain medications. So you don't necessarily have to be a diabetic to suffer a hypoglycemic incident. However, it is very common in our diabetic patients. for the reasons listed here. Remember, the brain can only use glucose and oxygen for fuel and for energy. So we generally start to see central nervous system manifestations of hypoglycemia when the blood sugar drops below 60. Now this will be patient dependent. Sometimes you'll have a patient with a blood glucose level of 30 that is still awake, and sometimes you'll have one with a blood glucose level of 30 that is unconscious. So this will be patient dependent, but kind of textbook, we're looking at less than 60 milligrams per deciliter, we start to see symptoms of hypoglycemia. So the first thing to happen when our blood sugar starts to go low is our sympathetic nervous system is stimulated. Have you guys ever been in that state where you start to get a little jittery? It's kind of probably at the time you're getting hangry if you haven't eaten. Start to get a little jittery, a little irritable, right? So the sympathetic nervous system takes over and creates this cascade of symptoms here on the list. Now, the central nervous system manifestation is listed over here on the right. This says brain glucose deficit. So when the brain doesn't have enough glucose, these are the symptoms that occur. So we have the sympathetic nervous system manifestation and then the brain deficit manifestation. Oftentimes, diabetics know when their sugar's dropping because of these symptoms. And if the sugar drops too fast, it might be too late for them to take in some food. Some diabetic patients carry around glucose pills or simply just candy laced with sugar. So how do we treat the conscious hypoglycemic patient? Well, this is rather easy. We simply just give them sugar by mouth, or sugar PO. And this can be our oral glucose paste, this can be their juice, their candies, whatever they have on hand, right? So we want to give them sugar. But at the same time, we have to consider managing them with complex carbohydrates because sugar is going to be burned off rather quickly, right? And we want to introduce complex carbohydrates that last much longer, right, and can sustain a blood glucose level. Depending on the reason for their hypoglycemic episode, they may need to continue assessing their blood glucose level, or we may need to continue doing that for them. If someone's taken too much insulin, or if they've taken a long-acting insulin, their blood sugar will continue to drop. So how do we manage the unconscious hypoglycemic patient? We don't want to give anything by mouth to an unconscious patient if we can help it. And as a paramedic, we have some other options. We want to manage, of course, the airway as appropriate, but we don't really want to place an advanced airway because, hey, we plan on waking them up. So our first course of action is to initiate IV access and administer dextrose. Remember, dextrose is just simple sugar. So it's simple sugar straight to the vein and straight to the brain. So it works very quickly. In our realm, we can give either D10, D25, or D50, and that might not make a ton of sense just yet. Remember, D10, D25, and D50, the D stands for dextrose, right? And they're all just percentages. So D10 is D10% dextrose, and in the next couple slides, we'll go over that in a little bit more detail. But in either case, your ultimate dose is 25 grams of dextrose. That's your max dose, 25 grams of dextrose. We want to titrate to the patient's response. We don't want to just slam 25 grams of dextrose and then skyrocket their sugar into the 200s or 300s. We want to titrate to effect. But remember that 25 grams, up to 25 grams can be given using a D10, D25, or D50 solution. So in the red here, big old warning, ding, ding, ding. If you're giving D50, remember to use a large catheter. And as you're administering it, you want to check for extravasation by pulling back pretty frequently on the syringe, bringing blood flow back into the syringe and then continuing to push it. Remember, D50 is super viscous, it's very thick, and if it extravasates, I mean, it goes outside the vein, it can be very necrotic to the tissue, and we certainly don't want that. For pediatric patients, it's weight-based, right? Most pediatric doses are weight-based. So for patients up to 1 year, we're only going to use D10, okay? Remember, the higher the percentage of dextrose goes, the more viscous it becomes. So our little guys and gals, we want to give the D10 because it is the least viscous. Okay. Okay, and the dose for this now for up to 1 year old is
0.2 grams per kilogram of the D10 solution. And if you wanted that in milliliters per kilogram, it equals 2 milliliters per kilogram. For 1 year or older, we're giving a half to 1 gram per kilogram, and we can give that in D10, D12.5, or D25. And you can see in the red here that that equals either 5 to 10 milliliters per kilogram if you're using D10, 4 to 8 milliliters per kilogram if you're using D12.5, and then 2 to 4 milliliters per kilogram if you're using D25.
Well, shoot, what if we can't obtain IV access? Well, we do have another choice, luckily. So we have a medication called glucagon. So if we're unable to secure a peripheral IV, we move to glucagon. Glucagon is given intramuscularly or intranasally. The adult dose of glucagon is 1 milligram. The pediatric dose of glucagon is 0.5 to 1 milligram. Now remember what glucagon does. Remember, glucagon lives inside our body. So when we give glucagon intramuscularly, it takes a little while to work, but it works its way to talk to the liver. It talks to the liver, right, to break down the stored glycogen. Right? All that stored glycogen in the liver and the muscle cells, glucagon goes and says, hey man, we need to unzip the suitcase and pull out the sugar because we need it in the blood right now. So in what instance would glucagon not work? Would glucagon work if our liver lacked the glycogen storage? Yeah, it would not work. Let's try to make some sense of all this dextrose and all these percentages, right? D10 or 10% dextrose means that there's 10 grams per 100 milliliters of fluid. D25 or 25% dextrose simply means that there's 25 grams per 100 milliliters. And 50% dextrose or D50 means there's 50 grams per 100 milliliters, which is why in a package of D50, like you guys have, there is 25 grams within 50 milliliters. So remember with basic math, if you half the amount of a medication, you can half the volume. So we have 25 and 50. If you half that again, you would have 12.5 and 25, and so on and so forth. You can see how all the numbers are divisible by 5 also. So with D50, 50 grams per 100 milliliters, if you divide 50 by 5, you come up with 10 grams. If you divide 100 by 5, you come up with, what is it? 20 milliliters. So there's lots of different ways that you can break this down in a much easier fashion. Dextrose comes packaged in many different ways. Remember, we have D10, we have D25, and we have D50. And they can certainly come prepackaged that way. But what if we only had D50 and we needed to make D25 to give to a pediatric, or we needed to make D10 to give to a neonate? That's not a problem. We can actually make a D25 solution and a D10 solution from D50. But remember, at the end of the day, we can always give every patient we have a D10 solution as long as it's enough fluid to contain the proper amount of dextrose we need to give. But we cannot go back the other way and give D50 to smaller children or neonates, because remember, D50 is very viscous, right? It's very thick, and their veins just are kind of fragile, right? And they're not mature enough to handle the viscosity of D50. Over here in the lower right, you'll see glucagon. I'm going to circle it here. This is how you'll commonly see glucagon. There's different setups. This is a very common one. And glucagon must be reconstituted. What you'll see here is you have a powder in a vial, and then you have another vial of fluid. It's just sterile water. It's 1 milliliter of sterile water. And what we need to do is, it's called reconstitute the glucagon. We simply need to insert a needle into the water and then take that water and insert it into the powder, glucagon, that's in the other vial. Kind of shake it back and forth a little bit, make sure it all dissolves, and then draw out that 1 milliliter, now containing 1 milligram of glucagon, and administer it to your patient. Remember, the adult dose of glucagon is 1 milligram IM or IN, and the pediatric dose is 0.5 to 1 milligrams of glucagon. So please watch the next couple videos here. They're going to help you learn how to turn D50 into D10 and or D25. And hopefully when we get back into lab soon, sooner than later, we'll be able to practice this. There's multiple different ways to do it, more ways than are on these videos, and we like to play around with different ways and see what works for you. Hyperglycemia. So we're going to chat about hyperglycemia for a moment, and then we're going to talk about two specific hyperglycemic conditions. So hyperglycemia, by definition, is when the blood glucose levels rise above 120. Now, if you're thinking, oh, my blood sugar is 125, but I'm not hyperglycemic. Well, kind of by definition you are, but you're not symptomatic. Generally, our symptoms don't appear until blood sugar gets a little bit higher. And for us in the pre-hospital care environment, we do not treat hyperglycemia until it is over 300 milligrams per deciliter. So remember, it's not only diabetics that can become hyperglycemic, but it is more common in diabetics than in the normal population. So just like kind of we learned earlier when we learned about the onset of diabetes, the signs and symptoms of hyperglycemia are listed below, kind of the ones that we'd already spoke about. So our treatment for hyperglycemia by itself, just a hyperglycemic patient, blood sugar is over 300, is simply fluids, and in hospital, they will receive insulin. So let's talk about that a little further in a couple different hyperglycemic conditions. DKA, or diabetic ketoacidosis. It's a term you've probably heard a lot, but might not be intimately familiar with what it is. Diabetic ketoacidosis primarily occurs in type 1 diabetics. But remember, DKA can occur in patients prior to a diagnosis of diabetes, and this will be the first onset, essentially, of diabetes, type 1 diabetes. It can also happen in type 1 diabetics who are poorly controlled and allow their blood sugar to rise high or don't take their insulin properly. This can also happen with type 1 diabetics with the onset of some type of stressor. Remember, we talked about in all the other endocrine conditions, oftentimes people have the underlying endocrine conditions, but a stressor will essentially exacerbate the condition. So like an infection or a surgery or some type of stressor. So what actually happens? Remember, type 1 diabetics don't make their own insulin. So blood sugar levels are allowed to rise incrementally in the bloodstream. If we don't have the insulin to allow the sugar into the cells, then it just keeps accumulating in the blood, and essentially the cells are starving, right? When this happens, our body tries to eliminate that extra glucose, right? This is what happens. This is why there's excessive urination or polyuria. So these patients are going to be severely dehydrated. But what also happens at the same time is our body thinks it has a backup system, right? We know we can only use glucose for fuel, but since we can't get the glucose into the cells, the body says, hey, let's use some other tissues, let's use some fats, let's use some proteins in our body, amino acids, let's break those down and turn those into sugar so that we can use those. Well, great. Remember, that was that term called gluconeogenesis. So we're creating new sugar from non-carbohydrate sources. So the body sends the fat and the proteins to the liver to go through this whole process to make the sugar for the body that we need. But in the meantime, it causes a byproduct, an acidic byproduct called ketones, hence the ketoacidosis. And you guys probably, again, have heard that word, but maybe aren't 100% sure what it is. Well, ketones are just simply the byproduct, right? The acidic waste product of gluconeogenesis. Well, it's acidic, right? So the body needs to get rid of it. So do you guys remember the breathing pattern associated with DKA? That's right, Kussmaul's respirations. Remember that fast, deep breathing pattern? Well, that's an attempt to blow off these ketones, blow off these acidic byproducts and get them out of the body. And ketones happen to smell fruity. That's why we say these people have a fruity odor on their breath. Ketones just happen to smell fruity. So how will patients in diabetic ketoacidosis present? Well, in addition to the three Ps, there's some pretty nonspecific symptoms. Abdominal pain, however, is very common in DKA, especially in pediatrics. Now we know they will be breathing fast, right? So tachypnea. Lung sounds should be clear unless there's another underlying etiology. And with the Kussmaul's respirations should be that fruity odor on their breath. It smells kind of like juicy fruit. If anybody's ever had juicy fruit as a kid, I can actually smell it right now just talking about it. Okay, so let's look at the questions at the bottom here. So the patient's going to be dehydrated, possibly hypotensive, and with electrolyte imbalances. Why is that? Yeah, kind of like we talked about dehydration. They're going to be losing a lot of fluid. The body's attempt to get that extra glucose out of there. Hypotension, well, that kind of comes secondary to dehydration, right? If we have low fluid volume, our blood pressure will be lower. An electrolyte imbalance, again, that piggybacks on losing fluids, right? With fluids, we lose electrolytes. Hypocapnia. Let's think about this. Why? Why will this patient be hypocapnic? Good. With the fast breathing, right, they're going to be breathing off that excess CO2, right? So tachypnea will put them into a hypocapnic state. So in the ER, they actually use a predictive value above 24 to rule out DKA. Somebody's end tidal is above 24, they rule out DKA in the emergency room. And fruity odor on breath, well, we just discussed that, right? The ketones that they're blowing off, that waste product, happens to smell fruity.
So what do we do? So in addition to supporting ABCs, rehydration with isotonic fluids is the mainstay of pre-hospital treatment of the DKA patient. Remember, these patients are pretty severely dehydrated. So the best thing that we can do for them is fill them up with some fluids. It will cause a pH shift where insulin will work better in that setting. What the patient really needs is insulin, but they won't generally get that until the hospital. That's usually reserved for the hospital. They give insulin incrementally while, of course, reassessing blood sugar because they don't want to drop it too fast. But a big pearl here, such a big pearl that Maryland actually removed fluids from the pediatric protocol for DKA. So, warning, warning, warning. Cerebral edema can result when giving the pediatric DKA patient fluids. Okay, so the recommended dose is 10 mils per kilogram, 10 milliliters per kilogram, and it's really only reserved for if the pediatric patient is truly in shock. Studies have shown that cerebral edema in adults in this setting is very uncommon.
Hyperosmolar hyperglycemia syndrome is the last condition we're going to talk about. HHS typically occurs in type 2 diabetics, unlike DKA, which happens in type 1 diabetics. HHS, you will see named many other things. The list on the bottom here gives you a few. You'll see HHNC, which is hyperglycemic hyperosmolar non-ketotic coma. But generally the coma has been taken out of the name because only 10% or less than 10% of people present with a coma. You may see HONK or HONK, which is hyperosmotic non-ketotic, HHNK or HHNS. They're all variations of the same word. So hyperglycemic non-ketotic coma, non-ketotic meaning there's no ketones, which we'll talk about the pathophysiology in just one moment. In HHS, Just like in a lot of these other endocrine emergencies, there's often an underlying stressor or illness. Remember that stressors or underlying illnesses favor a high blood sugar environment. So the body's already mobilized its sugar stores. And then remember, the kidneys will try to make up for this by excreting excess sugar in the urine, which is great, except for in the case of HHS, the kidneys actually get pissed off. The kidneys stop functioning properly and they start getting clogged, right? So the kidney's ability to filter out sugar decreases. So what happens is the kidneys are still filtering water. Water's leaving, but sugar's staying, which puts us into a hyperosmotic state, right? And with the extra sugar in the blood wants to pull liquid out of other vascular spaces to dilute that solute, to dilute the sugar. So now the plasma is sucking fluid out of our other organs, including the brain. The one kicker here, though, is what makes this a bit different also from DKA, is that type 2 diabetics do have some of their own insulin in most cases. So these patients don't develop ketoacidosis. They have just enough insulin so that the body doesn't start to go into gluconeogenesis and try to create the sugar from those other non-carbohydrate sources. So patients in HHS do not develop ketoacidosis. So they will not develop the Kussmaul's respirations. They will not develop the fruity odor on the breath without the ketones. Patients in this state will generally be altered. Remember that osmotic shift in the brain can cause confusion, disorientation, seizures, all the way to unconsciousness. Remember, these patients will not have ketosis. They will not develop ketones, so they will not have a fruity odor on their breath. And their end tidal, in the absence of some other underlying pathology, should be within normal range. These patients also will be much more hyperglycemic than DKA patients. Remember, their kidneys stopped filtering out the extra sugar, so their blood glucose level will be a much higher range than DKA patients. The pre-hospital care treatment for HHS is primarily focused on supporting ABCs and initiating fluid resuscitation. The definitive in-hospital treatment for these patients would be the continuation of fluid resuscitation, possibly insulin infusion to supplement their own insulin, and treatment of the underlying stressor or the underlying infection. Oh, hey guys, we're all done. Woo! For the most part. I've added this short video if you guys like to watch it. It's from a show called Live Rescue. It's a fire department that responds to a man in a park who's having a hypoglycemia-induced seizure and shows their treatment modalities. It's rather short and it's pretty good, so I'd like if you take a look at that. Then go ahead and move on to the next step, and I look forward to seeing your posts in the discussion board.